Hello, everyone. I hope you're all having a great EPF Congress. And so welcome to this session. And today we'll be looking at a subject that kept coming up yesterday, which is accessing digital health from reimbursement to the digital divide. And I'm Neil Bertelsen, and I'll be moderating today's session. So I was originally a patient advocate, but I've spent the last couple of decades working with decision makers. And recently, over the last 10 years, working with many HTAi bodies around the world. So I'm just as interested as you are to hear what our esteemed panelists have to tell us today on how digital health solutions can be assessed and paid for by our health systems. What can we learn from the international perspective? And how can involvement with the patient community help strengthen decision-making on these digital health topics? So let me start by welcoming our panelists and introducing them to you. And so to explore the payer perspective, we have Corinna Hartrampf. She's the Senior Policy Officer for the International Association of Mutual Benefit Societies. And Corinna will shortly be giving our keynote presentation and also joining our panel to bring that perspective to us. To bring us the HTAi perspective, we have Anna Toledo-Chávarri. She's the coordinator for the patient involvement strategy at the Spanish network of agencies for assessing national health system technologies and performance. That's also known as RedETS. And Anna will be joining our panel to explain the emerging disciplines of HTAi bodies assessing digital health solutions. To share insights from a multinational perspective, we're delighted to welcome Bleddyn Rees. He's the founding director of the European Connected Health Alliance. Bleddyn has seen and experienced the implementation of digital health solutions in numerous countries, and we'd be delighted to hear from him what he can share with us from that perspective. And last, but by no means least, we have Paola Kruger, who's going to bring us the patient advocate perspective. So Paola is a patient advocate, but also a EUPATI fellow, and she'll be reflecting on the emerging role of patient involvement in helping shape access to digital solutions, but also discussing some of those potential challenges that digital health solutions may pose to some patients. So we're delighted to welcome the panel with us today. And to get us started, Corinna, I'm going to hand over to you so you can get us thinking about digital health from the payer perspective. Over to you, Corinna.
Thank you very much, Neil. I'm happy to be here, and I'm happy to be here to present you the payers' perspective of digital solutions, and I will start with the opportunities of the digital solutions. Then I will tell you briefly what we do as payers, and then in the end I will come to the challenges of the digital solutions. So at the beginning, let me briefly present you. I think the slide is not working. No? Does it go to the next slide? Because when I'm clicking, it's not working. Now it's working. Okay. So coming to, let me briefly present you AIM. AIM is an international and European umbrella organization of health insurance funds and mutual benefit societies. Our members do compulsory health insurance or complementary health insurance, or they do both. We have currently 55 members in 28 countries. We do not only have members in Europe, but we also have members in Latin America, Africa, and Middle East, where mutuals are really rising. We cover currently 240 million people, and we all share the same values, which means we are not for profit. We are based on democracy and solidarity. That means we do not make any risk selection, and we fight for access to healthcare for everybody. So coming to the opportunities of digital solutions, when you take, for example, rural areas where there are not many very doctors, or when you need a specialist and in a specific hospital and the hospital is not around the corner, teleconsultation can help to give access to treatments, and it can also save costs. We all have heard already that prevention is better than cure. So for this, health apps can help a lot to keep the patients healthy, and this would also save the costs, and is also better for the patient to be healthy. Also, when it comes to chronic illnesses which require daily monitoring, the patients are able to closely monitor vitals such as blood pressure or glucose levels, or wait, and then they can send it to the doctor, and that they can all do comfortably at home. So there are advantages. Also, take rare diseases. We need, for rare diseases, not everything is known in your country about your disease, because they're not very often. So sometimes you have to travel into a different country. Teleconsultation could help here as well to get a treatment started, and this can also be done comfortably from home. So teleconsultations are useful also for a prescription for medication, a quick advice for an urgent problem. But of course, in the end, a face-to-face consultation is still necessary to keep up the level of quality. So teleconsultation cannot replace completely the face-to-face consultation. What are we doing as payers? So our role is, of course, the reimbursement of treatments. When it comes to reimbursement of telemedicine, video consultations in Belgium, for example, were not reimbursed by the compulsory health insurance until March 2020. This changed immediately with the COVID-19 situation. During the COVID-19 pandemic, there was a lockdown and patients could not see, the doctors could not go. So initiatives were developed, which were temporary, but suddenly teleconsultation was possible. So the mutuals in Belgium had quickly to adapt, and there were different ways of reimbursement because before it didn't exist. New reimbursement codes, usually without out-of-pocket payments, for the patients were introduced. A second option was that they took the existing reimbursement codes following the usual reimbursement rules. And the third alternative was that they took the reimbursement codes following the usual reimbursement rules. But in addition, they had to introduce a special code for care at a distance, which had to be declared as well. So suddenly telemedicine was reimbursed and it was possible. In France, it was similar, except that the telemedicine was already implemented in the period from 2014 until 2018. And the teleconsultation can be reimbursed by the health insurance, which was done by any doctor. The reimbursement was that a teleconsultation was billed by the teleconsultant doctor at the same price as a face-to-face consultation, and the reimbursement rules were the same for a face-to-face consultation. Before the implementation of telemedicine, although it was introduced, it was rather slow. And that was probably due to the fact that the patients had more faith in a face-to-face consultation, and they also did not have a lot of trust in the technologies. During the COVID pandemic, because they were a little bit obliged to, patients used it and they were quite satisfied with that. And also the telemedicine was broadened due to the COVID pandemic because a face-to-face consultation was rather difficult. It included much more healthcare providers than before. So suddenly it was possible to do a teleconsultation for speech therapists, for psychologists, even midwives. Which criteria do the payers use for the reimbursement of telemedicine? In Belgium, new conditions and reimbursement related to care at distance by healthcare providers were introduced. So the patient had to give his consent, and after being informed about the procedure of the teleconsultation, the patient has to be physically and mentally able to work on a computer, and the duration of the service should stay realistic. Also, the amount of services was limited. That was due to the fact that to keep the quality of care, in the end, at some point, a face-to-face consultation had to be done. So the patient has to see a doctor. And the service, that was also the condition, should be provided for the continuity of care during the pandemic. And the similar conditions were in France. France wanted to have a coordinated pathway. So that means the doctor, a GP needed to be consulted at the beginning, or the professional provider should at least know the patient, and then the teleconsultation could take place. And also the patient had to give consent. Exceptions from the coordinated pathway were possible when the patient is under 16 or when the patient does not have a GP or a GP is not available. Now I come to, we do not only have teleconsultation, digital solutions also cover, for example, health apps. So that started to develop not only because of COVID-19, but already before. I give you an example. In Germany, the Digital Healthcare Act was introduced in Germany end of November 2019. And it gave the possibility that doctors could prescribe a digital medical device and that then health insurers would reimburse it. So the aim of the law was to create a framework to make it easier for health insurance funds to provide appropriate and economical care. The medical diagnosis is obligatory for the reimbursement, but now the question remains, how does a doctor know that, for example, a health app gives an added value for the patient? So the medical devices regulation has changed a lot. There was a revision, and now much more apps have to go in evaluation, which means that manufacturers now must submit evaluation concepts to the Federal Institute for Drugs and Medical Devices in Germany that prove an added value for patients. So when a medical device has undergone this process, a doctor can be sure that there is an added value of this app and he can prescribe it, which leads again to reimbursement by health insurers. It is expected that the offer of apps will be multiplied because manufacturers have an incentive now to get the certification in order to get reimbursed. Similar to Belgium, also the reimbursement of health apps is now, since January 2021, is now possible to get a reimbursement. So you can see it's very recent. There is 3 levels of classification. So on the first level and the second level, they're rather technical. When a health app, for example, and it is a medical device, it has to show that it complies with the CE marking as a medical device, and it has to meet the GDPR rules. Then when it passes the first level, it goes up to the second level, where it has to pass interoperability and connectivity pass. And once this medical device has passed these 2 levels, then companies can submit data showing that there is a medical app, that the medical app provides clinical and socio-economic value to end users to get reimbursement. Again, then once the 3 levels are passed, in the end, the app will show an added value and the reimbursement can be done. So you can see that a lot has been popping up, and this has been very recent. So I will conclude that remote consultations will not, although the measures are temporary, they will not disappear anymore. They will be complementary to physical consultations. But of course, there will be challenges of digital divides in healthcare, and they will remain, and we have to work on that. So patients have, in general, they have a lot of trust in face-to-face consultation, and even though teleconsultation can be very helpful, it cannot completely replace a physical contact with a doctor. So at some point, a doctor has to be consulted physically. Then, of course, there is a lot of, doesn't count for all patients, but there is a fear sometimes in technologies, especially when you take older population. They might not be so familiar with this. And then I come to one of the most important points, which we as payers always tell to the European institutions and other authorities, that we really must work on digital health literacy. Because when you take the digital economy and society index, it shows that 4 out of 10 adults and every 3rd person in Europe has a lack of basic digital skills. But a patient must know how to download an app to be able to use it. A patient must have access to internet to be able to do a teleconsultation, and the internet must work well. Otherwise, it's not very useful. So we have to work on the digital skills, because otherwise we will have a big gap and the access to healthcare cannot be guaranteed. So that is very important. And yeah, just to close, as I said, the remote consultations should be complementary to physical contact. It can help. It's an added value. It's a plus, but it's a safe way to follow up on chronic diseases such as diabetes and to ask for prescription. But for other sudden complaints, you should always see a doctor. So a complete replacement of digital solutions will not be the case, or is not preferable. Thank you very much for your attention.
Thank you so much, Corinna. And you covered so much in that short space of time. So thank you very much for that. And some of the key words I heard you mention over and over again was maintaining quality, making sure that these digital services are realistic. You also talked about consent from those taking part of these. And I think what you showed, especially over the last 2 years, is how fast moving this has been, and this need to maintain trust and build up skills, not just within the health system, but more generally across the population. So you covered a lot of bases for us there, so thank you very much. I'm sure you all have questions in the audience. Before we go to those questions, I'd like to give an opportunity to each of our panelists to give their point of view as well. And we're going to start with Anna. And Anna, we know you work in Spain with the HTAi bodies in Spain, and you're starting to think about digital solutions and how they can be assessed using HTAi processors. And so I'll just pass to you to give us some thoughts on where you are and what your experience has been so far, Anna. Thank you.
Thank you. Good morning to everyone. Yes, I am a health technology assessment officer. Health technology assessment is meant to evaluate with systematic assessment the technologies that are brought into decisions in the healthcare system or maybe in local contexts as hospitals. What we do is to gather all the available evidence with the preference of randomized control trial as assumed as best evidence. And with those, we evaluate if they must be, for example, covered by in this case, by the Spanish government in the universal coverage list that we have, or maybe introduced in a hospital, or just to inform whatever decisions need to be taken. What I'm going to speak about today is the case. I think digitalization is proposing a lot of challenges for assessment, and internationally we're seeing that it's going to grow a lot, the technologies that are going to knock on our door and that would be necessary to assess in the future, as Corinna has told us. There is telemedicine, there's also application, there are also some management, data management technologies, for example, that are going to change a little and impact the healthcare system. In Spain, we are currently assessing telemedicine for teleneurology, and I want to speak a little bit about this case and how it challenges how we assess technologies in the current moment. In teleneurology, what we have to address more normally in health technology assessment in HTAi, we evaluate effectiveness. Does the technology does what it's expected to do? And safety, does it have any unwanted consequences, secondary effects? If you think of medicines, that is what we normally do, or medical devices, we are currently looking mostly at health outcomes, clinical outcomes. But when we went to address telemedicine, these outcomes we felt weren't enough for the assessment. So what we did is we gathered. We looked at some frameworks that are currently being developed for this assessment, but we also gather stakeholder groups, mostly clinicians and patients, that would be the ones that are applying this assessment. And they ask us to broaden the questions, as Corinna has told us. The main worries for clinicians and for patients were about access. Would everyone in Spain, we have a universal coverage law, so we have to guarantee that everyone is able to access to telecare. Some of the studies that we were evaluating used, for example, an iPad as a technology. Is it feasible to do this? Or so some of others require a broadband that was very with a lot of capacity, so maybe it would be necessary, would be available for everyone. We were also regarding at what points of care would it be feasible and easily implemented these teleneurology consultations. as Corinna said, we also saw that it's more feasible when the consultations mean only clinical conversations as follow-ups, but what happens in diagnostics, or, for example, in monitorization, or when new symptoms appear. And this may also need some in-person consultations to be gathered, because many subtleties of the consultation may be missed. For example, mental health problems, concomitant problems, and also there were ethical questions that we need to ask. Thus, maybe diagnosis communication may be done through an online consultation, but would be acceptable for a patient in that hard moment to be consulted by online and not in person. So we think that we have to rethink how we do assessments. We have to engage participants on the framing the questions. We have to ask us organizational questions, technical questions, and more broader questions than just effectiveness and safety to be able to evaluate correctly or properly these issues. So thank you.
Thank you ever so much, Anna. And you covered a lot of bases as well there. And so you built on what Corinna was saying, but this focus on evidence, I think, is quite interesting. I can see there's already questions in the chat about the kinds of evidence or how we would assess perceptions of digital health and how that can also be an evidence point that we can bring into this. And we'll come to those questions in a moment. And I think it's really interesting the way that you were saying, maybe this is where we have to rethink how we do assessments. And maybe that's something we'll explore later in the panel. Moving on, Bleddyn, I'm going to pass to you next. And you've got this experience of seeing the implementation of digital health within different country perspectives and internationally. And so I'd be very interested to see, what you can tell us, what you've learned over the years of doing this.
Thank you very much. And so good morning, everyone. And thank you for the invitation to speak to you today. First, a little background on the European Connected Health Alliance so you can understand where my comments are coming from. We're a not-for-profit organization. We have 70 international geographic multi-stakeholder ecosystems, not easy to say, helping to transform health and care systems in regions and countries. A key challenge for us is global sectors versus national healthcare systems. And what this leads to is countries reinventing the wheel and the not invented here syndrome, resulting in variations in quality and inefficiency. So key work for the ecosystems is transferring best practice, lessons learned and failure across borders quickly. So in my quick 5 minutes, I'm going to just focus on 8 points. So the first is digital health, mHealth, eHealth, connected health, whatever label you want to use, is remedial. We do not talk about digital banking. Banking is just digital. Health must be just digital. And so a rhetorical question is, why are we still using the label digital health or even digital tools? 2, many digital tools are not linked to reimbursement. Healthcare providers pay for them as part of their delivery service. For example, electronic health records, appointment text reminders to patients, for hospital apps for doctors, such as finding the latest clinical guidance using AI to search. Health providers will assess their technical, clinical, and financial merits themselves. 3, digital inclusion and exclusion. We must leave no one behind. Digital skills and education for staff, patients, and carers are an absolute priority, and other sectors can help. For example, financial services, where banks train customers on digital tools and security. Skills in education are so important. The ECH Alliance created a thematic skills ecosystem, and I believe EPF has an important role here to play. 4, when we talk systems, it's important to understand the distinction between ICT systems and the physical health system, i.e. buildings, treatment pathways, organizational structures, because these can constrain digital tools. 5, health data is all about access and control, not about ownership, even though I know there's a later panel today that's talking about ownership. I expect that this panel will come back to this subject as well. In relation to data, a couple of key things to say. It's about real-time data. It's about quality of data. There must be transparency about use, benefits, and results. We need simple, understandable communication about health data, and we need trust. 7, we need to keep a sense of perspective. It's not about digital tools, technology, or equipment. It's about people and about healthcare services for people, where we are improving outcomes, generating better efficiency and quality of life and wellness for people. 8, there are many key ingredients for success of digital tools. What I want to emphasize is 3 things. Firstly, digital co-designed with clinicians and patients. Again, EPF has a key role in this. Secondly, industry must avoid over-promising and under-delivering. And then thirdly, we need to save time for patients and for doctors. For example, one login for doctors for all systems, and for patients giving your name and address and other information once, not repetitively. Thank you.
Thank you ever so much, Bleddyn. And there are some recurring themes that are coming up here, really, as well as some new themes here. So I liked the way that you started this with this not invented here syndrome, which we hear a lot, but also the fact that it's really important to share the failures as well as the successes, and that's how we learn. And the difference and the connectedness between the IT systems delivering, if you like, the digital tools with the rest of the system, including the building and the infrastructure in there. And I'm sure we'll come back to some of those points later. But you ended there with talking about trust and co-designing with patients. I think they're really, really important topics. And it leads us nicely into hearing from Paola to give us this perspective of where you see the opportunity for the patient community, patient advocates, to be part of this, to be part of the shaping of this as we move forward to more access to digital health solutions. So Paola, I'll hand over to you.
Thanks very much. And hello, everybody, also from me. Yes, it's so very interesting, I think, and I totally agree. I definitely think that digital solutions have to be developed with patients to be really useful. Some of the problems that Anna mentioned at the beginning about being able to assess a device, I think they could be solved if they involve patients from the beginning. So you wouldn't have to wonder whether actually people can use it, if you've done it before. So once that is ensured, we will probably also have less problems in demonstrating that they're worth investing the health system's money. This is one important lesson, I think, that we learned through patient engagement in medicine development. And I think we should keep in mind when we develop digital solutions as well. The new regulation on medical devices that was implemented at the end of May means that many digital solutions will fall in the device definition and will have to be developed following strict criteria and with an increased use of clinical trials to prove their efficacy and safety. This is really important because it gives the opportunity to collect a wide variety of data from patients and use questionnaires that can be useful to assess the value of digital solutions. What I see different in HTAi involvement is the opportunity to collect more data from patients thanks to the digital device, therefore offering a wider picture of the patient's experience. And I hope this information will be used to add a stronger patient's voice in HTAi. Saying that, I think that patient advocates, patient experts, patient organizations should make a big effort to get trained on digital health. We talked about training, and I think this is fundamental. I'm not saying that patients should know everything about tools in detail. This is probably something that can be done in our own therapeutic area. But knowing more about the different types of tools, how they are developed, and what are the main features is something that, as patient representing other patient, we should do. So exactly like we did for medicine development, it's time to study and get informed again.
Thank you very much, Paola. And this is a key theme that I think everybody's touched on is how we all work together, how we build trust. And we've seen some really good examples of that from the panelists already. I can see there's a lot of questions already come in for the panelists. So I know that we have about half an hour left. So I think in the interest of time, I'm going to start digging into those questions for the panel. And I'll go to a general one at first, which is from Christoph, which is, could the panel comment on what types of data patient associations could collect on the value that patients perceive from digital health? So what's the value to patients in collecting data on where they perceive that value to be, maybe to help point reimbursement authorities and HTAi bodies on where there is most value from the patient perspective to help with those access decisions. So Corinna, I'm going to come to you first of this, because I know that from your presentation, you've been doing a lot of thinking across your associations and the insurers about how you make sure that you're paying for value. And would some data from patient associations help with that?
Yes, of course, especially our organizations, the Health Insurance Fund and the Mutual Benefit Societies, use patient data a lot. We get a lot of, I'm talking about billing data, but we use them a lot in order to be able to know what are the problems of the patients, what are the diseases, and in order to offer the best services. But of course, on the other hand, and we agree that innovation is a plus, but the problem is really to balance a little bit innovation, but also how to make it safe that health data is not misused. So we're working actually a lot on that and try to help. There are a lot of frameworks and proposals now for AI, and there's also guidelines for apps to make them safe. And we work on that and try to give proposals how to make it safe and to contribute to that so that it can actually happen. But the concerns of the payers are that health data is very sensitive data, that it can be misused. And that is one of the big issues. And of course, at the same time, not to stop innovation.
Okay, no, that's really clear, Corinna. So it sounds like that the patient groups can be collecting some evidence on these perceptions from the patient communities. I mean, you touched on a lot of topics there that relate to trust and relate to how people feel about their health data. And I think it's really interesting for you to sort of show us that the payer community is also grappling with those same questions from their side as well. They're worrying about the same kinds of issues. Yes. Anna, I just want to come to you because you mentioned evidence as one of your key elements when you were thinking about how HTAi needs to think about digital solutions, but also you talked about, maybe we have to look more broader at the evidence base when we're making decisions about digital solutions. Is there anything that you think that the patient community, the patient associations could be collecting evidence-wise that would help here?
Yes, I think that patients have an opportunity here to reframe how the questions have been answered or what questions have been answered. So maybe through gathering their experiences, for example, they can say and help specifying what population are going to benefit and what population are not going to benefit. What are their expectations around the technology is really helpful for us. And what are the preferences regarding the outcomes, what they want from that, are they expecting from that technology? Is that being complied by the technology or not? That is really helpful for us to assess each technology. Other evidence a study may be more difficult, but qualitative studies may be gathered, or there are patient associations gathering real-world data, for example, from devices that are really helpful or making the studies that require more capacitation. But I think a good starting point may be the HTAi, the Organization of Health Technology Assessment International, that has resources for patients just to frame these questions that could be addressed. They have little form a form that gathers this kind of question that can be used by patient association. It's online and maybe can guide what patient can provide for assessment.
Excellent. No, thank you. And thank you for that idea about looking at HTAi and seeing how we can build on the questions they've already developed to bring in these digital related questions. Bleddyn, I just want to go to you and just from your perspective of working in multiple countries and thinking about what evidence is most useful when people are making those decisions around digital health solution. Have you seen any examples, or are you seeing that the patient associations are involved in that decision-making process or providing evidence into that decision-making?
Yeah, so I think the question is actually a great question as well, by the way. But I think that EURODIS, for instance, did a great survey on digital and tools. But of course, EURODIS is rare disease. And rare disease patients are probably more likely to want to share data because there are so few of them. And therefore, if they don't share, the chances of them benefiting from research are reduced. Whereas what we really, I think, need is a much bigger survey that is across member states so that we have a picture across Europe rather than small groups that aren't necessarily representative of the entire population of, say, Europe. And the important point about this is that countries have very different cultures and trust levels. So in Finland, the citizens of Finns are very trusting of their government and much more willing to see data shared. That is not true, for instance, of Germany or other southern countries. So there's a divide between the Nordics and the Mediterranean countries. And I think that we need to get to the bottom of this by understanding, and that's where patient associations can, I think, with large scale surveys, make a great contribution. But I also think we need to be very clear about when we talk about data, what do we mean? What data? Because there are some very different challenges to types of data. So there needs to be clarity about what health data we're talking about. And I do think we need to be cognizant of the fact that there is genuine fear, often perhaps that is based on not having enough knowledge about security and privacy. So these are very real fears that no one should be just dismissing out of hand as, just don't worry about that. We need to communicate clearly. In terms of tools, you're seeing more and more development of national health app libraries, for example, as one way of talking about it. So countries like Finland, Estonia, the Netherlands are developing health app libraries. But you then see health app libraries being developed by individual hospitals for their patients and for GPs for their own patients, where they basically prescribe an app which has been curated from a safety perspective, picking up some of the HTAi points from Anna, and are both around technical safety and clinical safety. And, I'm very encouraged to see, for instance, that that's now extending to schools. So schools starting to curate apps around health and nutrition. So you can see how this market is developing across Europe. And what we haven't touched on is there's a consumer market as well as a pure public health and system market. And the consumer market is more of the Wild West, where what is going into app libraries that are run by the tech companies. And increasingly, the amount of regulation is obviously addressing that to try and ensure that app developers are behaving responsibly and complying with laws that they might otherwise know nothing about.
Thank you very much, Bleddyn. So this Wild West thing, and that really strikes a chord with many of us who've tried to navigate these in the past. And it brings me to this wider question that came up over and over again throughout all of your presentations. And Paola, I'm going to go to you with this one. It's also a question from Stephen Bork, which is about this digital divide and digital literacy. And what do you see as the potential solutions to make sure that we're addressing as a community this digital divide? How do we stop people being left behind?
Well, I don't want to repeat myself again, but I think that education is fundamental. Bleddyn talked about schools. I think they're the first step to be able to create the new citizens of the future and the new patients of the future, because unfortunately that's we get ill along our way. And so I really think that education is essential. I mean, I work for EUPATI, and as you know, we develop material for patients. We are developing currently a new module on digital health, because we think it's fundamental. And so if you don't train patients using patient words, this is something that is important to us. It's not just enough to have material. You have to make some material that is accessible to patients, and it's free. That's another important thing. And so give the opportunity for patients to of course, get trained, understand, because one of the great things I like about patient education is that it's a multiplier. It has a snowball effect. And when you train patients, they can train other patients. So whenever people tell me that training patients is useless, it's too complicated, I don't believe it for a second. I think it's most rewarding experiences ever. So I think that is really the key, and that as a community, as a patient community, we can get together and help each other out, as we've done in the past also on other issues. So I think this is really probably a simple answer, but probably the best answer I can give you. And I really believe in this.
Thank you very much, Paola. And I just wonder, from anybody on the panel, actually, it's made me think, just listening to you, Paola, and also what you were saying, Bleddyn, about the consumer app space versus the healthcare, so prescribed app space. Is there, I don't know the answer to this, is there the beginnings of some sort of stamp or accreditation that lets people just generally know what's being looked at and reviewed and what hasn't? Does anybody know if that exists or is planned?
That's what app stores do, because they are effectively curating for technical design by privacy and clinical quality. So if you get into one of those national app stores or regional app stores, you are getting that kite mark effectively of that this is safe. So I think that seeing that developed, but I think it comes back to also the education point. And one of the things I'd really suggest is that we've got to look outside healthcare and not be constrained by healthcare thinking. So what I mean is, I talked about banks. So banks are responsible for fraud that's committed on our bank accounts. So they are incentivized to reduce that fraud by training all of their customers on digital skills and literacy. So we can tap into that because they're providing that for free. And there's no reason why they can't expand that outside of their customer base to greater populations, and banks in every country doing it. Another example is sport, where professional sport organizations have substantial skills on nutrition and diet and exercise, obviously. And I can think of an example in Wales where the Welsh Rugby Union have taken their experts into schools and created a digital program for children to educate them about nutrition and diet and exercise. And the more that we can see that happening, and the more that patient associations can get involved with organizations like that to develop this education program and also give that quality assurance that you talked about, I think it's a great opportunity.
Thank you, Bleddyn. I'm just checking because we have a lot of new questions coming in. I want to go back to an earlier one, and Anna, this one I think it starts with you at least, which is, what are the similarities? You talked about your experience with this teleneurology project in Spain, and from thinking about subjects like that, what are the similarities and differences in a HTAi methods to assess these kinds of digital approaches versus a drug assessment? Are you already starting to see where those differences might lie?
Well, I think the main difference is that organizational context need to be assessed. I think we have frameworks that actually are watching to assess a lot of dimensions. The definition of health technology assessment has been recently actualized, and it includes more dimensions than from, for example, patient aspects or ethical aspects that should be assessed. Some contexts are doing this in drugs. But the main approach to this is to evaluate, in its case, if it's necessary or not to address these domains. And I think in digital context, it's really, really important to know where you're coming from, is your implementation context, what is going to be your process, and this needs to be assessed, I think, not with randomized controlled trials, but maybe with other evidence, with other means for appraisal. And I think this is a challenge for us, and we're going to have to learn how to do it to get better answers and to inform decisions in a better way. But I would like to give a note on access and what you were speaking about and how patient can access. And I think we also have to think about universal access and how patients that would not be able to engage in digital technology or because of mobility problems, for example, how they can be helped by patients or carers, or how local health centers may be a point of care for those patients. I think not everybody is going to be able to achieve capacities maybe, or not only education would be enough for every patient. So maybe other solutions from the healthcare system may help to engage everybody.
Yes, just bringing everyone together, Anna. I guess that's what you're saying is we need to be looking more broadly at the evidence base, but also working with all stakeholders, including the patient community, to really understand what these issues might be, who might benefit, and who probably won't benefit from some of these solutions. So thank you for that. I have a particular question for Corinna here from Christina. And Christina's asking sort of like if your organization plans to work with groups like EPF that were here today and other organizations to actually take this subject of reimbursement of digital technologies to the EU level. So you showed some good examples of what was happening in France and Germany and Belgium. How can that access be broadened across the EU?
Actually, I can say that we're not planning to. We are already doing that. We have regular meetings. We know CPME, the doctors' organizations. We know, of course, the patient organizations. We are also working with the hospitals and the pharmacists. We have regularly meetings to exchange about the topics. And I can say that we all work on the similar topics, and we all exchange about the point of views because every organization, every profession, or every institution has a specific perspective. But in the overall aims, we follow the same goals. And we meet at events. And I think in 2019, we did a big event with all the organizations in the European Parliament to present the health topics. So yes, there is a big collaboration. And of course, this collaboration is also very important.
Good, thank you. So it's already happening, which is great news. And Paola, I'm just interested, from your perspective, when you think about this from the patient advocacy perspective, and I know you work internationally, are you already hearing, we hear this about drugs, but are you already hearing this about digital, that there are certain countries where things are now available and others where this is not? Is that something you hear being debated amongst the patient community?
Oh, yes, very much so. I can tell you that in my country, and I belong to the Mediterranean countries that are skeptical about the government and everything else. But I can tell you that since the pandemic, of course, we also have an acceleration towards digital. And for example, at the moment, it is possible to have teleconsultations, televisits regularly on the NHS. So our NHS, of course. So it means that it's becoming also part of the system. It's not just something that we talk about, but it's part of the system. What I think is still missing is to really regulate what we need to do, because it's very easy to say, okay, we have a televisit, you talk to your physician, but then can you have a proper visit? Can you be assessed? All that part is still missing, it's still not clear. For example, I'm a neurological patient, can we have a proper neurological assessment? I know we can, but it's still not part of the system. So I think we've designed the framework, and we've come to the conclusion that, of course, digital has to be included. We're walking that way, but we're still not at the end of this road, I'm afraid.
No, we've still got a long way to go, and it reflects very much how, Corinna, how you started your presentation. You talked about making sure that we maintain the quality of care, that it wasn't the case that these digital solutions replace that quality care. And you talked about it being realistic. So we're hearing those threads come back, and maybe frameworks being developed or already in place in some countries that are starting to work through these issues. And it's good to see so much progress being made across the different stakeholders that we have represented in this particular panel. And it shows that a lot of thinking has been accelerated over the last year or two, probably due to COVID, I'm sure. A question for you, Bleddyn, which comes from Christoph. And I know you work at system levels across multiple countries. Where does this value argument come in that having digital solutions can improve the efficiency of the patient journey through the healthcare system? So, is that something that is a value driver for governments and health systems to take this up?
So I think that there's two parts to that question. There's a financial one, which is, if you're using digital, can you reduce the cost of the service? Therefore, you're able to provide more of the services, which touches on some of the questions coming in the chat about access and what I wish for in healthcare is honesty. So for example, it's simply not true to say that countries can give all of the services to all of the population that are required. That's just not financially possible. So the reality is that systems rationalize healthcare services. And what we want to do is have a system that is as efficient as possible in order to minimize the denial of certain services, frankly. And that's tough. So I think that's an important part of any innovation in the system, whether it's digital or otherwise, that you're always trying to optimize and have the greatest efficiency. But by the same token, what I think a lot of digital tools can do is they can make the patient experience, the soft experience, not necessarily the clinical one now, but make it actually less stressful. And when we think that, people are often facing the greatest anxiety when they're dealing with healthcare systems. I mean, I know from both of my parents who when they were seriously ill, would often hear nothing or recall nothing that a doctor had said to them. So digital tools that are able to provide information, or for example, family members access to summary care records, to be able to know what drugs they've been prescribed and why, that type of thing, I think is really important. And I do think this is where, again, going back to the idea of a survey and what patient associations can do, giving practical insight into the patient journey and on how digital tools can best be used and where it works and where it doesn't work would be a really important contribution. And this is where I think, picking up the point about organizations working together, we need greater collaborations between organizations to tackle these problems. No one organization, whether it's EPF, whether it's a trade association, is going to find solutions to some of these really complex problems. The reason that they haven't been solved is they are complex. What they require of us is more of us to work together constructively to help. So for example, if EPF is doing questionnaires, our 70 ecosystems are are an obvious vehicle in which to be able to enlist other people to contribute to a survey.
Yep. And so I think this multi-stakeholder working has been a thread that's come through each of your responses from the whole panel here, and collecting this evidence that shows where digital solutions can most help. So that's their key lessons. Corinna, we have a question here from Mariam, and I think it relates to your slide where you had this pyramid where you had these different levels of digital tools. And she's saying, are there any practical working frameworks that are currently used to classify these tools? So I guess this is a question of where we can go to look and see what frameworks already exist.
One of the framework which I already mentioned is the medical devices regulation. And as I said, there was just a revision. And before, not many apps were considered as a medical device. But now with the revision, more apps will be considered as a medical device. And that will lead to the fact that the manufacturers really have to prove the added value, because that is needed to get reimbursement. Because from our members, the problem was also you have a digital tool, and a digital tool is not necessarily great because it's a digital tool. I mean, it needs really to give an added value, and it needs to be a tool that gives also a solution to the medical problems that are needed. So that is important, but I agree what was said already before. For this, a collaboration is needed. And this medical framework, this medical devices regulation already exists. And then what I presented in Germany, for example, there is this German law now, and more will come up. The countries start developing their digital health strategies. I don't know all the law in the different countries, but I know that it's a lot of national e-health strategies are now put in place. So.
No, thank you very much, Corinna. So we can look up that, and Valentino and EPF will dig out those links to those particular regulations and make sure that we can share those in the future. So that's good. We only have 2 minutes left. So a very quick question to each of my panelists in turn, which is, a subtext of all of this has been building trust with all sections of the healthcare system and all the different stakeholders. So very briefly, I'm going to go through each of the panelists. What's the top thing you think we need to do to build and maintain trust in digital solutions going forward? And Bleddyn, I'll start with you.
Transparency of use, benefits, and results.
And Corinna, for you?
Yeah, I think it goes in the same direction. Transparency, legal frameworks to have rules in which direction it should go, not guidelines, but really binding regulation so that the patient can have trust. And of course, a lot of collaboration among all the stakeholders in the healthcare sectors.
Excellent. Thank you, Corinna. Anna, you're next on my screen.
I would add to those planification of implementations in the healthcare systems, not improvising and using at-hand technologies, but seeking trustworthy technologies to be implemented.
And Paola?
Well, I'm glad to be the last word as a patient. Well, I think it's co-creation with patients, because I think if you are part of the whole process, then you trust it.
Excellent. Thank you. And so the things that I'm going to take away from here, we didn't get to all of your questions, I'm afraid, but they were really good questions. The things I'm going to take away is that we really need to be working together constantly on this, that it's moving really, really quickly, that we sometimes need to think outside the box and think beyond our healthcare mindset sometimes to see what solutions might be out there. But we need regulations, we need guidance, we need to be developing those and co-creating those together. I would like to really sincerely thank the panel. I think this has been a fantastic discussion. I've learned a lot in this session today. So thank you to Bleddyn, Corinna, Anna and Paola, for you really sharing this perspective of how we can move forward in digital health. Thank you.
Thank you.
Thank you.
Thank you.